Good afternoon, ladies and gentlemen, and welcome to the August public webinar from NextGen Healthcare. This is Charlie Jarvis, Vice President of Healthcare Services and Government Relations, and I'm pleased today to be introducing three NextGen clients who will be talking about an area which I think is going to become mainstream in terms of how medicine is practiced in the next several years, and that is through called effective clinical data sharing. We have Chris Ozzie, David Ehrenberger, and Jason Greer, all from Denver, Colorado. They're going to be explaining the organizations to which they are a part of. And as you can see, our topic today is using IT to promote effective clinical data sharing. We have all the lines muted, so we do that for the benefit of our presenters as well as our guests. There is a chat bar in the on your screens. Please feel free to use that during the course of the webinar, and we will make sure that we get as many, if not all, of the questions answered by panelists. So let me turn things over to Chris, Dave, and Jason, and I think you'll enjoy a very, very effective presentation.
Thank you, Charlie. This is Chris Ozzie, a practicing family doctor in Colorado and the Chief Medical Information Officer at Colorado Associated Community Health Enterprise. And I'm going to start out the talk today, and then I'm going to turn it over to David Ehrenberger, who's a doc and Chief Medical Officer at Vista Adventist Hospital and their IPN. Going to be we've also Jason Greer on the line, who's the brains and the brawn behind our operation. We're going to be talking about kind of the who, why, and what of our data sharing arrangement. That's what I'm going to be talking about, and then David Ehrenberger is going to give us a peek into how their organization is actually using the tools that we've built at the Associated Community Health Enterprise. So the big question really in this talk is whether you'll be using your EHR as more than just an expensive progress note. Are you going to be getting anything more of it out of it than that? And my current hero in organized medicine these days is Atul Gawande, and the way he recently said it is that people in effective systems become interested in data. They put a lot of resources into collecting them, understanding them, looking at what they say about their performance, and then they spend a lot of resources devising solutions that'll solve the problems that data and experience uncover. And that's what we're all about, and the subject for today's talk. Now, if Atul Gawande doesn't inspire you, there's a lot of other things going on in organized medicine that are demanding our data if we're open to it. As most of us know, HEDIS, if we're involved in a beacon project around the country, we're being asked for our data. NCQA certification in medical home. The Meaningful Use EHR Incentive Program is requiring data. There's other NCQA certifications that are requiring data. So the demands on our data are huge these days. Health centers. I'm a doc at a community health center, in addition to working with CACHI, and we've been reporting data several years to the Uniform Data Set, the yearly report that we give to the federal government to justify our existence. And yet a few more reasons if you're interested in looking at your performance as a healthcare provider across practices. You can't do that alone. You've got to take data from various sources and be able to compare those. The data warehouse solution that we've developed and using also allows us to look at performance across different EA platforms, as well as even non-EHR data. So that's what we're using it for. The other reasons we got involved in the project was that it gives us some efficiency of scale. We're able to, as you all know, if you've been involved in this area, it's a lot of work to pull out data, develop reports and distribute those. And many of us are doing exactly the same thing at practices across the country and duplicating a lot of work. And these resources allow us to try to get some efficiency of the scale by pulling out the data together, developing one report and one way of displaying that. And finally, the big picture goal of the triple aim, improving the patient experience, the quality of care, and the cost of care. These will be highly driven by the data that we're able to pull out and share and being able to look at our performance. Years ago, based on some grants from AHRQ and the Colorado Health Foundation here in Colorado, we set a data warehouse under the auspices of the Colorado Associated Community Health Information Enterprise, or CACHI as we call it. CACHI goals originally were we could do about improving the quality of care. We wanted to be able to look at population health and start exploring that. We thought the future of medicine was in taking care of populations, like a population of diabetic patients or the population of patients who need a mammogram. We want to be able to look at variations in care and see where and why, when some providers or practices fell out at the top of the curve and why others fell out at the bottom, try and replicate the ones who came to the top and cull out the practices that were taking people lower. We wanted to be able to improve the quality of the data that came into the system from the input side. We wanted to be able to improve the disparities that we saw across different populations in a community health center where we were trying to take care of patients of all economic backgrounds. We also need to create reports for all of our stakeholders, and we also wanted to be able to do research and innovation. As I said before, originally it was research funded by AHRQ that made this possible. We saw the writing on the wall for value-driven reimbursement, meaning accountable care organizations. We see the future of medicine being reimbursed for the quality of the care that we're providing, and we need these reporting and improvement tools in order to rise to that occasion. So the data warehouse, the CACHI data warehouse, is organized. We have several EHR instances. At this time, we have 3 different major installations. 2 of those are NextGen installations. One of them is a GE Centricity installation. We're also able to pull data out of other databases. We're not doing a lot of it, but we would be able to pull data out of accounting databases, bookkeeping, Microsoft Exchange, or data, for example. And the first big step here process is trying to extract that data and bringing it over to the data warehouse. And within the data warehouse, we're transforming that data into usable, high-quality data. And that sounds very easy, but that was weeks and months out of my life trying to explain to data warehouse engineers where all this data could live. For example, an A1C in the HR database can be represented as a template field where somebody manually entered a number. It could be value brought in from a lab interface from Quest or LabCorp, or it could be another field that's entered by virtue of a in-house A1C testing machine. So next step is that data into the data warehouse in an organized fashion that can be reported on. And then once it's loaded into the warehouse, to do dashboarding on that data, we're able to do simple reporting, to do analysis, and then we're able to do drill down into information to try to find out where problems, highlights of the data live. What this means from the 30,000-foot perspective is that we're taking data that's originally transactional on the left side. So that's the transaction between the provider and the patient, or the provider and a lab provider, provider and insurance. We're taking that transactional data and we're converting that to an analytical database where the former one is optimized for data input, and the latter, the analytical database, is optimized for digging into the data, trying to figure out what we can learn from the data, looking at trends, etc. We're doing is business intelligence, and we're way down here on the lower left side, I would say, for sure, but we hope we're headed the curve here. Our goal is to try to get as high as we can on this curve between what's here as competitive advantage on the y-axis. And obviously, this is from a business application. Perhaps in the ADO world, that might stay competitive advantage. We might need to improve our quality to stay competitive, but really it's about improving patient care. And then on the x-axis is intelligence, the amount analysis that we're doing into the data in order to figure out what we're doing with it. Most of us are using standardized reporting to look at what happened. We've progressed to being able to do some dashboarding and performance reports. We're doing some query drill downs, but ultimately we want to be able to do some more sophisticated analysis of the data to see what's going to be successful for us, what's going to improve patient care, what the outliers are doing that make patients live longer, live better, make us successful as organizations and businesses. So we're going to look for, had a lot of lessons learned about where our data, lessons learned from this whole project. Oh, I've got a couple of slides switched around here, I think, so I'm going to skip to that one and then I'll go back to the prior slide. Good data starts with transactional software. Transactional software, and we've been very happy with NextGen, but it could be start with other non-EHR data, of course, or even other EHRs. That creating analytical database and the tools, the reporting is super work intensive, as I mentioned before. That extraction of the data from the EHR into the data warehouse takes a lot of work. It gets significantly easier after the first instance, but there is still ongoing work. Initial data mapping. Then we've got the data validation to think about. We loaded the data in. We did some validation. We made sure it was accurate and represented all the data that we needed, and then we could stop looking at that. But that has not been the case for sure. That data validation is an ongoing job. It's going to last as long as we're using this data warehouse. We'll talk a little bit more about attribution and formatting in a second. Lesson that we've learned is how much easier things can be if we can start with reporting on some of the bright spots, some of the care well done to providers, and that providers or organizations are going to be more interested in the data when they can brag about it, and then we can get into some of the areas of improvement, quote unquote. We've also learned that starting big, we chose 6 or 8 different areas, diseases, or preventive topics, and within those we have anywhere from 30 to 60 parameters we're trying to report on, and that was a huge chunk and very difficult to keep track of all those things. And if I were to do it again, we might start much smaller and then grow as the demand grew, and that we could keep track of the new items that we are adding into the mix. Leadership among providers really matters. The docs in particular have a big investment in making this data look good. And what we've done at CACHI is we've got a clinical committee made up of clinicians that meet every 2 weeks to plan strategy, make corrections, look at what we want to be capturing, look at data validation in order to improve the investment of providers on the front end so that we can have them open to it on the back end when they start seeing their data. It's a process, not a destination. That's, as I mentioned earlier, it's not something that's plug and play. It's not something that we hook up and watch it run happily along. It's something that needs nourishing and guiding as we go through template upgrades, software upgrades, new hardware, new data hosting hardware. And then it's important that we don't assume that providers are going to be anxious for our information. This depicts our experience and in giving data to providers. It's the 5 stages of data grief. I can't take credit for this one. I'm not sure who the originator is, but it's Elizabeth Kubler-Ross's, modeled after Elizabeth Kubler-Ross stages of grief around dying, and it's ironic because that can be so averse to data when really their whole training and background has been using data to learn how to do the things that they're doing and continue doing those. But this is a big deal to be getting feedback back on their performance. And our experience is that typically they start out with a fair bit of denial. That data is wrong, and oftentimes the data does start out wrong, and we take it back to the drawing board, fix it up, bring it back to them, and finally we get the data as close to perfect as possible. It is important that we not try to make it perfect. You can drive yourself crazy trying to make it perfect, and at some point we to providers, and providers accept it. This is as close to perfect as we can get, and they accept that well. See some anger from providers that they don't want us telling them how to practice. Luckily, we've got lots of docs involved, so we're using the same data, trying to do the same things. But there's often deflections like, "Oh, this isn't evidence-based. This isn't what we should be looking at. This doesn't really reflect the quality of my care." Then we might see some bargaining. I'm open to this if I can get that out of the, and then finally they start accepting the data, and there may be some depression. I thought I had ACs done every 3 months on 99% of my diabetics, and they realize that that's not the case, and it can be depressing. And then finally we hope we reach some acceptance that people realize that everybody's in the same boat. This is part of the process. I'm not being paid for it at this point. It's time to get going, get to work on it, get my team together, lead that team into quality improvement. I skipped a slide, a couple of slides back, but in the interest of time, Dave, I think I'll just go ahead and skip that one and turn it back over to you.
Okay, Chris, thank you very much. And as was pointed out earlier, David Ehrenberger, and I'm a family physician and the chief medical officer at a Vista hospital, and also of an IPA called Integrated Physician Network in the North Metro area. The IPA I'm involved with is about 160 providers, a majority of primary care physicians, in addition to cardiologists, orthopedists, OBGYN, surgeons, the idea. Now, what's kind of weird but unique about our organization is that we all use a single electronic health record platform, NextGen, and what's even weirder is that it's all dumped on the same it's the same database housed at by Dell in a server farm in Texas, and so it's all kind of web-based, thin client approach to computing in the physician's world. So the practices are all independent. They're not all part of the same tax ID number, and we all get our support through Catchy. So Catchy provides local software support, vendor management, as well as provides and powers our data analysis engine, so data warehouse and analytics, which I'll get to in a moment. So this first slide you have up here might occur. This is a mammoth storm, Katrina, as it's approaching landfall. So it's a little humbling. And this is kind of what healthcare is all about. My wife is a little histrionic when I bring out the slide, but many of us in the trenches know what I'm talking about. So what IPN is all about, with a partnership with a powerful company for support and data analysis and an excellent EHR vendor, is how to survive this storm. So, basically best defense is a good data offense. So things changing. So before I delve into my perspective on this, which is the view from the trenches, so what's happening in the North Metro area for Denver in our organization of independent providers using the same software, what are we doing? What's our around the use of data now that it's teed up in our partnership with Catchy? So I'm going to reflect on a mantra, if you will, of data sharing, and that mantra has three parts. The first one is good data is the fuel of performance and sustainability in healthcare organizations, like Chris referenced earlier. It's the fuel of success, really, both and business. The second thing is that good data is useless if it's not. So you got to do something with it. Is that physicians love data in spite of the 5 stages of grief. They absolutely love data, but only if they own it. So the trick is to get good data, use it, and the process of getting good data, as Chris referenced earlier as well, make sure the physicians are on the team to make that happen. So we have a method to our madness in terms of how we use good data. Chris has been articulate in outlining the top part of this slide, where HI refer kind to as generically. We have a kind of a private HIE. We're moving into the public HIE in terms of the state-run, but we interface with all sorts of the common labs and hospitals around here to get data in. That middle bubble with the faceless creatures are obviously people like me in the trenches. I also am still a part-time practicing physician. And then the data comes out on the other end on the right side. But what do you do with that? Well, that is what the quality improvement team approach. So it is multidisciplinary, and we, as part of Integrated Physician Network, as part of the service that we offer leadership and resources and services around quality improvement. So we are responsible for working with Catchy to create reports and tools, performance reports that are useful for practices and providers in the trenches. So the idea is to get great primary source for data and do, of course, the triple aim or value in what we're providing to our neck of the woods, to our employers and admittedly to the payers as well. So also read an ancient quality improvement proverb. Many of you will recognize this. You've been around long enough. Can't fatten a cow by weighing it. And the idea is that it's not good enough, as I referenced earlier, and that is just have good data. It's a good stuff. So the concept is that we feel like in order to be competitive in healthcare in 2011 plus, and in our community to combat the well organized and effective organizations out there that are integrated delivery systems or single ID organizations that have tremendous infrastructure around health information technology and quality improvement. We know we have to get good data, but we have to understand that if data is king, then the king's boss is or the use of data. We have to optimize the EHR experience for providers such that make their life as efficient as possible, while at the same time capturing the key data elements that are important to drive the other end of the quality engine. Performance improvement and collaboration referred to through the Quality Improvement Committee. Ethics, that's what CACHI is all about, what the good Dr. Tanazi was referring to. Coaching, we're all about coaching. Physicians and healthcare organizations in the private sector, as maybe many of you know what you're talking about when you're talking about coaching. But coaching is really a facilitated system. It's a process of facilitating the change of systems, whether it's in private practice internist group or a surgeon group, but to be methodical about it and to use data to make it happen. So who's the master? Now, I use that to kind of bring it to a big front in healthcare, which is all too often information technology is presented as the master of providers, not the other way around. We, people, humans, should actually master the technology, meaning it should be subservient to our needs. It's a lot of effort. Fortunately, with NextGen and with folks like CACHI, we're making that happen. So HIT defined. I had this defined for me about a year ago, actually at the user group meeting here, and I thought it meant. I learned that it's actually a sequence. It should be better health through better information, through better technology, and that's the right priority. The method to our madness then includes care model. I'm not going to go into this, but it's a systematic kind of organic approach to use data to inform your organizations and systems and practices in a community to work towards common goals. So you're leveraging your IT, you're embedding decision support, delivery system design, for instance, to reduce readmissions or what have you. And so you really energize and power both your provider teams as well as your patients to get better outcomes, which many of you know about. Institute for Healthcare Improvement has been rolling this out for quite some time. But the bottom line is use data and use it in a systematic way where you begin with the question, what do you want to do? And then experiment with different ways of doing it. Use data to inform your process to decide what the best way of making it happen. Extremely important in any healthcare organization, and of course, particularly in ours, where we are kind of herding cats, right? We have a bunch of practices that do have, not on the same balance sheet and that sort of thing. Also, are disciplined, and we try to be extremely disciplined, but we're imperfect. But we want to make sure that in the process of using data, that in the process for moving beyond outcome reports to performance reports, that we understand the power of data demonstration to change behavior. So one of our favorite tools is the so-called annotated run chart. So an outcome report might say, for instance, that family practice B has an A1C overall, average A1C of its all of its diabetic practices of 6.8. It doesn't tell you anything about whether that's good or bad, because if it's gradually getting worse over time, then that's actually a bad thing. If it's gradually getting better over time, then that's a good thing. So an annotated run chart really informs your organization about which way you're going. So it's to the future and to improvement. So key features of annotated run chart, arrow, green arrow for us, is a section of which way we're right direction to go. So when you're talking to a room full of surgeons and primary care docs and orthopedists, they look up here and they don't have to have me explain what it means. know that down is good. And an annotated run chart also has a benchmark. Which way are we going? And we usually try to use national benchmarks, or at least those of regional performance of other healthcare organizations. We label slides as much as we can with changes that we did either across our IPA or certain parts of our IPA. See if the changes in process and system are making a difference. And in an example, the second change worked, whereas the first one did not work. That's kind of background. In the next 10 minutes, I'm going to go through some examples of what we see effective in our organization, using the powerful tools from Catchy to get good data, and using systems of quality improvement that I just outlined to use that data to affect better outcomes. Of course, diabetes, can't talk about it, any quality improvement unless you talk about diabetes, just required. So we just, use this, probably familiar to most of you, at least in non-8.0 KBs, or 7.9. And so diabetes, so you have to make sure there's the right bucket to put the data in. In this case, making sure that you can capture the PHQ score for mental health screening, for depression, and that wherever that data is entered within the EHR, that it goes behind the scenes into a single data bucket, which makes Dr. Tazi's and his job much easier in terms of mapping that data within the data warehouse for reporting. Powerful discipline around data input, you get great output. This happens to be, this is a real registry, although the names have been removed to protect the innocent. And so this is a typical registry. It is ratified so that we can focus on those patients who are at highest risk and for intervention. There, it's July 14th, 2011, 11:28. I actually did a presentation the next day and had this slide in there just to kind of show the power of a good data warehouse and live reporting on your database. The new vital signs. So these are diabetes outcomes reports. Again, this is probably familiar to most of you. So this is the provider level. It happens to be me and my performance with 65 people, my 65 diabetics. For my practice, which has 11 providers, we have 577 people with diabetes, and then across all of IPN, we have 4,119 people with diabetes. This is an example of the notion of being informed as an organization or provider about your empanelment. Who are your patients at risk, and what is their overall condition. So we take this kind of data and we use it in practices. It's an example of a practice data wall. It happens to be the family practice that I work at. And so this is displayed publicly. We update this data wall once a month as we get new data and new projects going, and we use that to power change in behavior and to encourage people in what sometimes is difficult, which is, change. The Integrated Physician Network quarterly general leadership meetings, we also share our data. You'll see many other examples coming up in just a moment, but this is the overall performance report of the organization. So on the left, we have quality initiatives that we are working on, from diabetes to ischemic vascular disease, including colorectal screening, mammography, and immunization. We also are working on our patient experience and, of course, cost reduction, which I'll get to momentarily. So the oval, red oval, of course, indicates the trend of performance. Doesn't mean that we are doing great, it just means we're going in the right direction, with the exception of one of those items. So this report was from June. Run charts of actual data from Integrated Physician Network. Again, arrow, which way to go. I know this is seems silly, but when you're talking to groups of people who aren't used to looking at data, you got to make sure the tool means something to them as well. So in this case, we have 3,918 diabetics at that moment in time. This data is actually several months old. And the best practice is at the top. we use the best performing practices in an organization to inform our quality improvement process. We go out there and figure out how the heck they are doing it. Are they forging their data, or are they actually doing something better? Report control, as you can see, some room to go across the organization. Goal is over 85% of our diabetics with LDL less than, 85% getting an LDL, and then we're doing great in terms of getting good control on those diabetics that we are measuring, of course. Another example of good data in, right? So we want to make sure that in the process of our care, somebody's coming in for a sinus infection. We have made it a standard operating procedure, thanks to how easy it is really to use the NextGen product in this way, to make sure that no matter what the complaint, if somebody's a smoker, it's addressed at the time of the office visit. So an MA does this. No matter where in the EHR you're entering the information about do they smoke and when do you last ask, or do they drink, or what, have they had their depression screen, it's still captured easily and therefore easy to report on. So in our practice of all of our patients at Broomfield, we are hitting about 95.4%. Are we up to date with or current with asking whether people now you see what circled down there, 4.3%. Now you know that many of those patients we're actually counseling. Unfortunately, we're not putting data in the right data bucket in our practice for all patients. We are for our IVD patients. So IVD patients, we had a performance improvement project whereby we were sure that we were clicking this button here, advice, when we actually counseled them. Now, of course, this is a painful thing to do for a lot of docs because they've already typed in or otherwise noted in the chart they advise their patient to quit. But free text entry is not a data bucket you keep in mind. So we trained around this piece, and we actually have MAs check this little box to make sure we can capture it. So when we narrow our mining to our ischemic vascular disease patients, we're doing a decent job, not a great job, but a decent job with counseling our smokers. And for breast cancer screening, again, it's about data input into the workflow, documentation, makes it easy to report. So across our practice, we are hitting about 67% of our eligible patients for mammography are getting timely mammography. That sounds kind of lousy, and I would say it is kind of lousy, but for the fact that nationwide it's probably more like 45%. This is performance not just in the practice, but now across the organization, and this is confirms that it's about 5% across the nation. So we do performance improvement projects in various practices and slowly roll it out across all organizations. Best performing organizations at 70% currently. Cultural screening, same sort of thing. We had a recent bump up in performance. Pneumococcal vaccination. And then influenza immunization. Doing this for now a couple years, and you can see in 2010 we were pretty mediocre. We focused on it, used the data, looked at how we did things, and have had a substantial improvement. And one of the practices is 90% of eligible and appropriate immunization of folks. Reduction, we're kind of new to this business, but many of you on the phone probably are much more sophisticated around cost reduction. But we're focusing on generic drugs, and this is not a very good slide. It violates my rule of using a chart. But nevertheless, the idea is that focusing in on something as easy as switching folks from expensive PPIs, which cost $225 to $4, is a great opportunity for us to offer better value to the market. The last run chart just demonstrates that when we have our general membership meetings, we share our data at the practice level, and in those meetings means the identity of the practice is revealed. So the green dots up here are several practices that actually are associated with one another, and they are outliers. And so using this kind of information can point out who's actually not on the team. These practices actually have been given notice that they will no longer be members of our collaborative organization. Down below is a new practice that joined. Initially looked great, but then we got real data to show that they were not bad, but not great enough. I'm going to summarize now. Data is a key power of data sharing. Open doors to other things. Anybody who's been trying to do a patient-centered medical home understands that if you have systems by which you can get and use it effectively and use it around improving your systems of care, it means it's a lot easier to play the PCMH medical home game, or for that matter, whatever accountable care organizations demand of our organizations. So in Integrated Physician Network, we currently actually have 9 medical homes as of now. For you about some wild and crazy ideas, such as group visits, which I thought was absolutely Looney Tunes until I studied literature and talked to people who are a heck of a lot smarter than I am. And group visits work, and we prove it with our data in this particular practice over a year and a half, actually a year in this case, but confirmed in a year and a half study, dropping the average A1C for high-risk patients by 1.5 or 15% overall. In terms of keeping your board certification and qualifying for a medical home, NCQA recognition, and all this stuff, there are other benefits of participation in a quality improvement organization. Then return on investment, contract performance, of course, clinical integration. Across our integrated physician network, we have been using single signature contracting now for 3.5 years legally, because we can show that we're using data to improve care. The EHR is fantastic for better charge capture and appropriate coding. NCQA recognition I mentioned. We can play the various pay for performance programs and can contribute to how payment methodology reform is rolled out. And then we can be a player in accountability. So ultimately, that the data sharing is at least in sustainability as well as performance. Take-home message that takes a village. Collaboration and a new culture centered on the importance of data, getting data and using it smartly. Requirement utilities like EHR and great data warehouse and reporting tools. Leadership, so I say by the people and for the people. Well, I really mean physicians and other healthcare providers with a common vision. And then finally, it's in the village that sustainability is found. The product of what we're doing is market-relevant value of data sharing. Summary with a quote that summarizes this pretty well. Data is a campfire around which organizations huddle for heat and light. The me is that neither the heat nor the light yield a solution. The solution emerges out of the huddling. So thank you very much for your attendance this afternoon. This is our contact information. I'll open it up for questions.
Thank you very much. We did have a couple of questions, so before we break, I want to get to those. One question we had for any of you is, can you speak to the ownership among providers more? How did you get the engagement of your providers initially?
Well, to tackle that, we used fear. The IPA the reference had another name and had more providers, and yet we discovered in about 2004 that we had to shut down because we were beginning to engage in illegal contracting with because the FTC was looking dimly on single signature contracting unless you had a single tax ID number. So we had to shut down, which meant we suddenly, over a very short period of time, lost our leverage in the marketplace. So we had to think of another way of doing it and came upon the notion of clinical integration. And it means that people can either take a cut and pay in our neck of the woods by 20%, they can join a mega group, or they can play ball with us. And that means that they agree through formal relationships with our IPA to use the same software, to use their data, and to participate in quality improvement efforts.
Let's see.
I should say that physicians love data, and when they trust it, they begin to be hooked.
Okay, I thought there was more than one question. I see only one. Let's give people a couple more minutes if they want to put questions in. Meanwhile, Delinda, there was some interest in the slides, so why don't you show people how they can download a set of the slides?
So in just a moment, you'll see a box pop up on your screen. And I will pull a copy of the slides in there. And when you see that file, you can click on it and hit save to your computer, or hit download to save it to your computer. And hit it now. It's emailed to you as well. If you have any trouble, don't worry about it.
Oh, the question that just came in, David. How important is the user-friendliness of the reports in terms of adoption?
Great question. I think it's essential they're usually user-friendly. The more they are self-explanatory, the more they are relevant to a provider's practice, the better. So I think actually I'm going to zoom up here to a slide that I think that Chris skipped over. Is that right, Chris? Did you do this? I don't think you did this slide. And oops, I guess I didn't get that right. At any rate, you have to have good data means that it means something, and it means that it's relevant. It's here. Let me see if I can do it right. Yeah. So this is anatomy of good data. So data improves the health of patients. So it has to be relevant. So it has to mean something to providers. It has to be displayed in a way that makes sense to them. They have to gain trust in the data, that there's a connection between what they do and what they see in terms of the outcome reports. So it has to be, again, easy to report. So you're not reporting data that's like 8 months old. It has to be pretty current for docs to pay off on it. It has to be validated. So we often have the situation where we'll get data and the provider or provider group will say, well, that's nonsense. And it's up to us to say, well, that's fine, but you need to sit down with us and let's look at the HR itself and let's map data. And sometimes we find that there is an error, but often we've done our homework and we know it's true. And once they actually do the work to see that what the report says is true, very powerful to get engagement. And then the point number 6 here, I think, is really key, and that is that good data actually sells itself.
Great, sir. Let's see if we have any more coming in. Okay. Vision for how the writing software will change and improve in order to continue to drive adoption and improve care.
Well, I get an excellent example of that in where NextGen is going with HQM. HQM did not exist when we started our project with NextGen in 2005, and admittedly, we're only beginning to use it now. But I bet Charlie will agree that it's going to become half of the equation as we move into the future. Half of it will be the EHR, and workflows that optimize the clinical experience interacting with patients. Half of it will be reliable, efficient tools for data mining.
Yeah, I think that's very true. And for those of you that are clients who are on the call, you want to pay special attention to both our webinars as well as our upcoming users group meeting about how the health quality measures is going to be developing. For those of you that are not clients, watch our future public webinars because we'll be sharing some of that information as the modules become commercially available as well.
Sure, I'll take another crack at that as well.
Sure.
Just from in our evolution at CACHI, what the next generation of reporting needs is that what we would love to have is a more customizable data mapping tool. So we that someday soon, instead of all the expense of using a database in here, that there will be tools out there that will allow us to identify the data sources and bring that into the data warehouse. And then also on the end user, the analytics side, there's a balance between how useful the data is because you can display it in a hard-coded format, but then we would like to be able to go from that hard-coded format to a user ad hoc experience that they can start with a canned report that we present to them, but they can tweak it from there to say, well, I want to look at just these patients or this time period, or they're on this medication. So those are a couple of the areas that I see in our future as a data warehouse and the software we're using.
Okay, go one more. How difficult is it to produce new reports out of the CACHI warehouse? Across this, across the IPA.
Yeah. Do you want to take a crack at that one?
Oh. Sure. Can you hear me okay?
Yeah. Yep.
So I think the answer is it depends, and so it depends entirely on the complexity of the query and what we're trying to solve for. And so if it's data that we've already mapped out, then it's actually very simple. If we're looking for something obscure, then we start from the beginning and identify the data source, transform it into the warehouse, and then produce the report. And so I guess, yeah, it depends on what the goal of the report is going to be, if that's not a vague enough answer, guys.
Good, Jason. Let me ask a follow-up question here. For any of you, do you see value in receiving reports on smartphones and or tablets? Another point, can users view the reports via browser? So three pieces to that question.
Crack at that, Charlie. We haven't tried anything on smartphones, and it would be hard to imagine the usability of that because we're trying to look at changes over time and get bigger pictures. But I'd love to be convinced otherwise to have an excuse to start developing an application for a smartphone. Tablets, I think you can get some great looking data on tablets, and that's we are do that. We are displaying. The reporting software that we're using is SQL Services Reporting Services, or SRS. Did I say that right, Jason?
That's correct, Chris.
Okay, and that the display of those reports is all web-based. So, and all tablets are running web browsers, so very usable on a tablet.
Okay, I'm not sure. Did you answer the question via browser?
Yeah, we are. It's all displayed via browser.
Okay. Well, I believe it's just about at the top of the hour. I don't see any more questions. So, on behalf of NextGen, let me thank our three presenters, and let me thank all of you who have remained on the line. I encourage you to follow up in future, watch for future things around this whole area of data sharing, as we'll be sharing some other clients' results and their stories in future public webinars. And for clients, watch very closely, especially a pre-conference session that we're running on the power of clinical data sharing. Thank you very much on behalf of the folks from Piano Vista and CASCI, and thank you all for attending today.